Welcome back to the Diet Doctor podcast with Dr. Brett Scher. Today, my guest is Dr. Ignacio Cuaranta. He's a psychiatrist from Argentina who is sort of leading the field along with Dr. Georgia Eads and a few just very select psychiatrists who are using low-carb ketogenic nutrition and overall lifestyle interventions to help their patient with mental disorders and psychiatric diseases. And as we talk about in this interview, psychiatric diseases aren't all that different from body diseases, if you want to call it. A lot of it has the same baseline, the same cause of disorder, and the same potential treatment, much of which needs to focus on lifestyle. So I really enjoyed his perspective, and I think you'll get that from his approach. And also how he's sort of leading the way in Argentina. This movement isn't quite as big in Argentina as it is in the United States and in Europe. So he's sort of blazing the path there, which I really appreciate. Also, it sort of ties in a little bit with how Diet Doctor launched their Spanish website. I wish I could have done this interview in Spanish, but my Spanish is not good enough at all. But it's reaching out to a whole new market, a whole different world. This is truly a global event. So if you want to hear more about this and read the show notes, go to dietdoctor.com. Otherwise, I hope you enjoy this interview with Dr. Ignacio Cuaranta. Dr. Ignacio Cuaranta, thank you so much for joining me on the Diet Doctor podcast.
Thank you for having me, Brett.
Yeah, it's my pleasure. Now, you came all the way from Argentina here in Florida for the Low Carb USA conference, where you're giving two talks, really. You're giving one in English, and then one, they're having a special day specifically all in Spanish, and you're giving a talk there as well.
Exactly. Yeah. There's two talks that are going to be about the same, but in both languages in order to reach more people and be able to join more people into this world.
That's great. And Diet Doctor has recently launched their Spanish version of their website as well. So when we were speaking last night and your dad was there, he asked us if this interview was going to be in English or Spanish. And I said, I wish I could do an interview in Spanish, but it would have been a very short interview if it was. So here we are. Thank you for taking the time to join us today.
Thank you.
So you are a psychiatrist based in Argentina, and now you are part of the whole low-carb movement as treating your patients with nutrition for their psychiatric disorders. So let's rewind for a second and go back to your training as you're learning to become a psychiatrist. Was there any discussion about nutrition in any of that training?
There was no discussion whatsoever, and this is one of the things that really launched me into doing the investigations myself. Actually, one of my core beliefs is that we study function, we study dysfunction, we study anatomy, we study lesions, injuries, but there's no mention whatsoever to how our brain is functioning, what fuel is using. Does it have available fuel? Does it not? Is it permanent fuel or is it transient? So that really is what moves me into studying this.
Right. And, my take on psychiatry, as, from what I've learned in medical school, was that it really was focused on drug treatment for chemical imbalances, and that was really about it. And let's face it, the drugs that are used in psychiatry have some pretty significant side effects. So it's a huge field that even if you can't get people off all their medications to control their psychiatric disease, if you can reduce the medications, you could have a huge impact in terms of daily function and how people feel. Isn't that right?
Well, that's absolutely right. In fact, I'm gonna have a big mention of what you just said in the presentations, because current practice of psychiatry is excessively pharmacocentric. It has an excessive pharmacocentric view, and it disregards many other things we could be doing for our patients. And if you only have one tool, that's the tool you're going to use. And really, in terms of side effects, that's one of the things that pharmaceutical companies haven't been able to reduce much. And when that in fact happens, when there's a drug that doesn't have many side effects, they are usually not as effective. And let's talk, for instance, SSRIs that are one of the most available drugs that are used in depression, in anxiety, in obsessive compulsive disorders, in psychotic disorders, for many, many functions. They have a plethora of side effects and adverse effects that are very hard to counteract. And those are drugs that are often very hard to deteriorate from patients, to take away. And I think that these strategies that I am using in my clinical practice can have a huge impact in reducing doses or even avoiding to prescribe a drug altogether. So that's...
Yeah, great point. Now, and it's interesting to think about the scope of the problem, because we talk so much about our obesity epidemic and our diabetes epidemic and the epidemic of chronic diseases that have plagued America and Europe and the world, really. But when you talk about psychiatric disease, it seems like it's fairly similar. I mean, there are estimates that a third of all people are going to have some mental health condition during their lifetime. The association of psychiatric diagnoses with reduced mortality and substance abuse problems and decreased quality of life, I mean, it's rampant. And I don't think it gets the same attention as, you can say, the other problems, the diabetes, the body problems rather than the brain problems. Do you think that's an accurate statement that has sort of been not given the attention it deserves?
That's absolutely an accurate statement. And in fact, psychiatric conditions tend to go underreported. They tend to thus go underdiagnosed, undertreated, thus chronified. So even when they are properly diagnosed, psychiatric medications oftentimes make matters worse. They make a bad problem worse because most of them have one of the most side effects that we see is weight gain. Oh. There's an average of between 2 and 17 kilos of weight gain over a course of a treatment, and that's about I think between 4 and 30 pounds of weight gain on average, and this severely increases morbid mortality among psychiatric patients. And like psychiatric conditions, the psychiatric drugs are dose dependent, and so if you have a severe condition, you will probably need higher doses, thus increasing morbid mortality and highly reducing quality of life and expectation to get better. It really highly limits recovery expectations in these groups of patients. And yeah, it is an accurate statement, of course.
Yeah. So that's pretty troubling. And there's a stigma associated with it. Nobody wants to be thought of as crazy or having a mental condition, when really it's just another health problem, but yet somehow it's got this stigma with it.
But even in patients that maybe don't make the cut to be diagnosed with, let's say, major depressive disorder or an anxiety disorder, they may have insomnia, they might be overweight, feeling really with low self-esteem, feeling very sad, having very low levels of energy, having very low levels of motivation, high compulsivity, and all of those makes your life very miserable, because it's like a vicious cycle. It's very hard to get away from it.
Yeah, and it's hard to make taking care of yourself a priority when you feel that way. So the rest of your health is going to suffer too. You're not going to exercise, you're not going to eat well, you're not going to take care of yourself. So it really is sort of a domino effect, isn't it?
It is a domino effect, and it is a vicious cycle, because most of those patients, what really troubles me is that most of them are really probably doing very well in other aspects of their lives, but they've tried many times to lose weight, to get ahead on their health, and they are following the usual guidelines, what the standard of care proposes, and they are doing it following the guidelines perfectly, and they don't get better. So after a while, they get frustrated, and they are probably going to drop out any type of treatment, and it is a vicious cycle that really troubles me.
Yeah, we focus so much on what people should eat, how they should exercise, how they should sleep. And we don't think enough of what's going on in their brain and how they're feeling and how they're responding to things. And that's, like you said, they may not meet the diagnosis of a major depressive disorder, but how they're thinking and what's happening in their brain function definitely impacts their health regardless. So walk us through this. So you went through your training, you learned to become a psychiatrist, you started your practice. How did you take the path less traveled? How did you differ from everybody else and start to think, let's look at how nutrition actually affects the function of the brain and see if that's going to help people? How did you make that transition?
Well, it's actually, let me rewind a little bit. Let us go back to year 2005. I was in my last year of med school, and we did with a friend, we traveled to Michigan and had an experience at the Beaumont Hospital. And then I there decided to do my experience at the weight control center, where they prepared patients for bariatric interventions, and with a kind of a classical approach. But it was with the meal replacement packets and with controlled calories, but was a high protein diet. They got a lot better, and then they prepared them for the bariatric surgery. So it is kind of like a 14 to 15 year route for me. And when the time came to decide what specialty I'd like to go in, I was between psychiatry and endocrinology. And psychiatry kind of like suited me a lot more than endocrinology, because there were other aspects that I didn't really care for, and really psychiatry, I have a passion for it. Really, when I study this type of topics, I get really invested in. And so I decided to go into psychiatry. But, inside of me, nutrition was always, and obesity was always a very important topic for me. So I kept studying it, even for myself, for my own health. It's something that doctors sometimes we put aside, and doctors ourselves are very unhealthy people. And that's kind of like a pretty strong statement, And so I did my residency in psychiatry, where I did, I focused on all of the psychiatric large topics, but nothing about nutrition. So after it was about 2013, I came across the paleo diet. I started doing it in myself. And then on year 2014, I traveled to France. I did a 3-month rotation at the psychiatric hospital there in Paris. And I kept studying and studying. When I came back, I had my girlfriend got pregnant, and she was my daughter was born in December in 2015. So I started studying ways to minimalize things in my house. It was pretty, it's a kind of like a different path. But I came across the intermittent fasting through a minimalist side.
Oh, interesting.
So there ain't more minimalism than intermittent fasting.
So not from a health perspective. It wasn't, let's try this for your health. It was to try this. You don't have to worry about what you're having for breakfast. You don't have to cook.
That was my first contact with intermittent fasting.
Yeah.
So I read the Brad Pilon's Eat, Stop, Eat. That was kind of like a seminal book in intermittent fasting. I read it overnight, and the other day was my first 24-hour fast. I just drove into it. I felt so great that I started studying, and I came across Dr. Jason Funk's work, and I started studying intermittent fasting in a more scientific way, trying to see what there was available in terms of studying and in terms of effects. And long and behold, I wrote to him and got to be able to travel to Toronto in Canada and did an experience at the intensive dietary management in 2017, April. And it was on. I lost 14 kilos and people was asking me, what are you doing? What are you doing? You know, like.
So did you go in there as a patient of Jason's and Dr.
No,
Funk, or you went
did,
as a practitioner to learn
exactly.
in like an internship?
I did an observership. They have an affiliates of observership program. And I had been studying for like over 2 years at the time, or a year and a half. So I kind of like reinforced a lot of the concepts that I had studied. And I started to implement, and the other side of the story is that I was, as the head of the mood disorders department at the neurological clinic in Rosario, one of the main clinics in Rosario, with a lot of patients coming in all the time. All of the patients came in through me for the psychiatric assessment. So I started seeing this very, very frequent pattern of metabolic disorders among patients. I started seeing all of these compulsivity traits, all of this deterioration in the quality of life, and I started asking more about nutritional aspects. So, you know, as a surprise came that they were most of them following, you know, the standard diet with carbohydrate ingestion without, you know, affecting their sleep patterns, with sedentary lifestyles. So I started, you know, with some patients that were suitable, and I have a very strong patient-to-doctor relationship. That is a very, very important aspect of my practice. I started implementing intermittent fasting, and they started getting a lot better. But in a matter of days, in a matter of weeks, I was able to start getting people off medication or detitrating medication, lowering doses. They start getting more energy level, start feeling better, start telling more people. So this is how it started.
You started with intermittent fasting. Was there a low carb approach as well? Because something that I've found is that intermittent fasting, with the clients that I work with, intermittent fasting is so much easier when you are eating a low carb, high fat diet. And it can actually be fairly challenging for a number of people if they're still following the high carb diet. So did you have to change the way they were eating first to then impose intermittent fasting, or did you start with the fasting? Tell me about that. Well,
actually, I myself, I was doing paleo, as I told you before. I was doing paleo before, and then over my paleo diet, I added an intermittent fasting protocols. Among my patients, what I find is that a 16-8 protocol or a 14-10 for women, but more around like 16-hour fast overnight. It is a pretty accessible initial strategy. It helps them a lot to gain perspective, take a little distance from what they are doing, being able to give more thought about their decisions and having to make fewer choices during the day. Because if you start eating low carbohydrate diets, a secondary effect of it is that you start reducing your appetite, reducing carb cravings, and highly reduce your compulsivity. So actually my first approach is about implementing intermittent fasting, but right now I do it as a combination. I also talked with my patients to reduce first place, reduce sugar or highly limit sugar. I try to tell them to avoid sugar altogether, but I am flexible in regards to health status and goals. I try to be coherent with what the chief complaint of the patient is and their goals. And so I try to tell them, okay, you're going to have and see a lot of better results if you do this synergistic strategy and not one or the other just to lose weight or be in good shape for the summer. My goal with my patients is quality of life. That's what I always talk with them.
Now that doesn't seem like a tremendous intervention. It's basically skipping breakfast to start, and you're seeing benefits with whatever psychiatric condition they started with. Just that small intervention, you're seeing benefits right away?
Absolutely.
Yeah, that's
absolutely.
Fantastic.
There is an adjuvant, it's more than adjuvant, an adjacent effect when they do just small intervention, okay? They skip breakfast and go straight to lunch, that your breakfast will be your at lunch time. and they start feeling better already. So they get excited and they get motivated and say, okay, what else can I do?
Right.
So it's not you that you motivated to get your patients to do whatever you think that they should be doing, but they start asking and exploring. And I always stimulate that in my patients. Study for yourself, have an exploratory and a growth mindset. Try to be progressively incorporating, better aspects to improve your quality of life. So I try not to be dogmatic or rigid in my interventions, because, when you are in the clinical practice, face to face with patients, you have to be more flexible. You have to be able to talk with different personality traits, different goals, different activity levels, different ages, genders, and all of the different types of patients that we see.
Yeah, well, let's get into the physiology of this a little bit, because when we're talking about diabetes, when we're talking about obesity, it makes sense why intermittent fasting, why a low-carb lifestyle, why those have a direct and very meaningful impact. Why does it help psychiatric conditions? Why does it help depression and schizophrenia and anxiety? And what is the connection there?
Well, actually, there are different explanations for different conditions. I believe that in anxiety and compulsivity, avoiding the sugars highs and lows with their compensatory mechanism by stimulating the secretion of cortisol, inflammatory cytokines, adrenaline, that puts you in a very vulnerable place. When you're all the time provoking that kind of response in your body. In depression, the lowering the stress levels altogether, being able, especially in the atypical depression, where it has more of an overlap with metabolic inflammatory conditions, is highly linked to hyperinsulinemia and the inability of the brain to use glucose as fuel. And that's why it's also linked to type 3 diabetes or dementia. And it is my hypothesis that it's not only affecting memory and concentration, but it's also affecting behavior. It's also affecting mood. I mean, how would you behave if your brain was not being able to use the main fuel that your body is using? If you have already fixed your metabolism to use glucose as energy, and your brain is not being able to use it efficiently, how are you gonna be? Are you gonna be tranquil, easy? Are you gonna be calm, or are you gonna be excited, desperate, irritable? I mean, it makes a lot of sense for me, and this is what I'm seeing in the practice, in my everyday practice. So it's not that you have to wait until someone is 60 or 70 to make an intervention, but my proposal is that we should be training metabolic flexibility and at an early age, even though you're not perennially in ketosis, but you can be in the outskirts of ketosis daily, doing some types of fasting, training the fasting ability, and being able to use both types of fuel. Some patients, let's more in the psychotic side, like schizophrenia, there are studies, very old studies, linking gluten, gluten sensitivity to schizophrenia. I recently had the opportunity to talk with a patient that was having hallucinations and really persecutory ideas since she was a child, since after some traumatic event at 5 or 6 years old. So, and she was 34 with continuous hallucinations. And after she read Dr. David Perlmutter's Grain Brain, she dropped gluten and started doing a ketogenic diet on January. And 2 or 3 weeks after that, all the hallucinations were gone. And and those are pretty, strong N1s and experiences and observations. And this is one of the limitations, because it's very hard in psychiatry to get people to do these types of investigations. So what we are seeing at the office is very important, because I don't think we should disregard the results that people are seeing. So sometimes many patients start to lose weight, but they see secondary effects, quote unquote, secondary effects on mood conditions. They start feeling better. They start seeing more mental clarity, thus making better decisions. If you are able to make, in fact, we are the results of the decisions we take moment to moment to moment. So if you start taking better decisions for yourself, that's better outcomes to be expected.
Yeah, that's a pretty dramatic example that you gave. And similar to the example that Dr. Westman published almost 10 years ago now, of the woman who'd had schizophrenia her entire life since she was like 6 years old. And then in her 70s, I think it was, is when Dr. Westman started treating her. She started a ketogenic diet. And again, within days, her hallucinations stopped and she was able to come off her medications. I mean, these dramatic case reports definitely have something behind them. But therein lies part of the problem, is right now we're in a world of anecdotal experience and case reports and not clinical trials and large bodies of clinical research. So it might be a little challenging to say, yes, this works, yes, this should be recommended, because what do we have to back it up? How would you respond when someone asks you that?
Well, actually, that's a great question, because I am addressing at my presentation on Sunday what we should expect and what we should not expect from ketosis, or what I like to call the pathways into ketosis. It's not the ketogenic diet or intermittent fasting or paleo or banting or low carbohydrate diets, but it's what you gain from those strategies and what works for you. And I think we should not see ketosis or the ketogenic diets or ketogenic pathways as the panacea, the end of it all, and the solution for everything. Is not the panacea for psychiatric conditions, and it's not the panacea for major depressive disorders, schizophrenia, bipolar disorders, severe anxiety disorders. But it is, and it could be, a great coadjuvant tool to implement for any psychiatrist or for any clinician or someone working at the primary care and being able to intervene and do prevention. I mean, how unsafe could be to prescribe to your patients that they eat real food, that they stop snacking all the time, that they start to talk with them about prioritizing sleep patterns, that they implement any type of stress management strategy. Those are very safe interventions, and we have a lot of evidence to say that those are safe interventions. So this is not what I'm proposing is not an excuse to irresponsibly dropping medications if you are under treatment, but it is a proposal to widen our views about what we're doing with our patients. Right. Because especially under severe conditions, because of what I told before in regard to the dependence, the dose dependence of the effects of psychiatric medications, we could really reduce and improve their metabolic profiles, even if we are prescribing medications. And there are also studies regarding the 16 and 16-8 protocol, joining, giving the time of the medication at the time of the meals, and kind of intermittent fasting protocols. They really reduces the metabolic derangement of the medications, especially antipsychotic, that are very, very tough on of insulin levels.
Yeah, so that's an interesting point you bring up about sort of how deep you need to go into lifestyle treatment to have a meaningful effect. Because there's always this question, do you have to be in ketosis to get the effect? Is it something about the ketones? Is it something about the metabolic shift? Or is a low-carb, healthy lifestyle with time-restricted eating, is that enough to see meaningful change? And that's also what makes it difficult to study from a scientific standpoint, because where do you draw the line, right? There are lots of studies that show low-carb diets don't work, and then they define a low-carb diet as 40% carbohydrates,
exactly,
right?
yes.
So it all depends on how you define it. So I think that would make it challenging from a psychiatric perspective. But what I'm hearing from you is you don't think it's necessarily ketosis. So we hear lots of things about how ketones are beneficial for the brain, whether it's in Alzheimer's disease or traumatic brain injury, and people talking about using exogenous ketones to boost the beta-hydroxybutyrate level to get a bigger effect and bigger penetration into the neurons. And there's studies that ketones decrease oxidation of neurons. There's studies that it increases mitochondrial function in the brain. So from your perspective, though, is there something beneficial about ketones and ketosis that you think would be helpful for psychiatric patients, above and beyond just healthy lifestyle and low carb?
Well, there's actually been studies that show that being in ketosis and a brain running primarily on ketones, on beta-hydroxybutyrate, helps to establish a more homeostatic state on the brain. It avoids it's what I like to call a more stoic fuel, because it avoids this external dependence on constant inputs of energy. So I think it's a lot about the energy availability and the energy quality, because ketones don't only provide for very large deposits of energy that are very reliable, predictable, thus providing for a brain state in which you have energy predictability. That's fundamental. And then you have neurotrophism. It's linked to a higher production of BDNF, brain-derived neurotrophic factor. It strengthens synaptic signaling. It helps provide a more physiologic environment for the brain. I'm a really big fan of Dr. Cunane's work about in brain evolution. He's also he's working doing a lot of work in relation to dementia, and really this is not about surviving. This is about thriving, and not what I'd like to tell. I'm focused on prevention, and I like to people to know about these types of strategies, to start exploring themselves, and don't wait until they start getting severe symptoms to start implementing, because it might be too late, and it might not gain lost functions back.
Yeah.
Because when we're talking about the brain, it's really an energy hog, and it really needs a constant fuel flow. And ketones provide that. I mean, especially in patients where they are insulin resistant. I love Dr. Tate Neyman's meme about the dam concept. I don't know if you're familiar with it.
No, tell me about
that. Like a hyperinsulinemic state is like it works like it operates like a dam holding on your energy stores. So if you are in a constant hyperinsulinemic state, you will be preventing or impeding those energy stores to flow. And if you start through fasting and low carbohydrate diets, you can start lowering those hyperinsulinemia, providing this ever increasing amount of fuel flow. And this is what I see in the clinical practice, because after a week or 2 weeks and 3 weeks of a well formulated ketogenic diet and intermittent fasting protocols, patients do start to wake up, do start to feel a lot more focused, more stable. They really reduce cravings, and they start feeling more energetic. And one of the main chief complaints that patients have at the office when they come is low energy levels, having very low initiative, seeing that they want to do something that highly differentiates from melancholic depression that they have no motivation to do anything, but they see what their goal, what they want. They recognize that they have everything they want, but they just don't have the energy to go with what they want to do. So I think if we can rule out all of those patients, we'll keep with other conditions that probably don't respond as well to this type of strategies.
What do you mean that don't respond? What kind of conditions wouldn't respond as well?
Because if we follow up on the example that I gave about atypical depression, that is more characterized with a metabolic overlap, with obesity, leptin resistance, insulin resistance, more of a personal or familiar history of type 2 diabetes and metabolic inflammatory markers. We also have typical depression, which is more like a melancholic, more related to childhood trauma. It has a later onset. It has a different profile, more linked to psychiatric conditions, maybe schizophrenia running in the family, and very low appetite levels, with clinophilia, that is like wanting to be in bed all the time.
Okay. So those won't respond as strongly to nutritional interventions and lifestyle.
That's what I've seen. And those are very, very hard or tough patients to work with, because there's no motivation. They are usually drawn to the consultation by a family member, if they have one, and they are isolated. It's a different subtype of depression, and I'm going to talk about that on Sunday and Monday as well. Kind of like trying to differentiate what type of patients I propose that they have the better outcomes with these strategies.
Yeah, and it's interesting to sort of draw the correlation to whether it's diabetes or obesity, that not everybody's going to respond the same, but also it's not a cure, right? We're not talking about a cure. We're talking about either a reversal of symptoms or managing disease or reducing medications, just like we can with diabetes. And important for people to understand, you don't just start the diet and stop your medications the next day. There can be some serious adverse consequences. So they need to work closely with somebody. But the problem, of course, becomes finding that person to work with, finding a psychiatrist or even a primary care doctor who's willing to work with them on this. So you're in Argentina. I don't know much about the medical culture there, but I'd imagine you're sort of stand out from the crowd as a rare breed. Is that the case? Tell me a little more about that.
Well, I do feel like that. This is also, there's a market, the demand that I have for my services, or what I do in my clinical practice, kind of shows what you just said, because I have high demand right now, and there's a huge subset of patients that really need these types of strategy and work close with a patient, because in addition, obesity and type 2 diabetes tend to mobilize patients to do a consultation with a nutritionist, with one of the mainstream weight loss professionals. But they might not, related to what I said before in relation to the underreport of psychiatric conditions, they might not do a consultation with a psychiatrist or with a psychologist because of the taboo, because of stigma, because they don't recognize, because some of the symptoms are harder to recognize. They might not even know that they have depressive symptoms, because they kind of maybe feel that they have low energy, they are overweight, it's all related to that, and they have a reason to think that. But the problem is that they go to the wrong professional, and there is why? Because there's not all of them. I'm not saying that everyone that is not doing what I'm doing is wrong. I'm far from that, but really I really get very mad when I hear stories from my patients. There is a high rate of verbal abuse about a professional abuse with obese patients, and you can see it on live TV. You can see in the Biggest Loser. We also have our version of Biggest Loser. Yeah, I mean, it gives me nausea to watch that program. Really, I mean, you see people suffering, you see people relapsing all the time, you see people with probably mental conditions or psychological traits. It's really, we have a lot of work to do, and this is part of why I decided to kind of like expose myself and expose what I'm doing in order to incentivize more psychiatrists to start prescribing or using, or at least increasing awareness and observance about this metabolic profile. And
so you're really leading the way for Argentina, it sounds like. Yeah. So what advice would you give somebody if they want to try getting on a low-carb ketogenic diet and lowering their medications, and their physician just isn't hearing it? What kind of advice can you give them?
If they are taking medications, I think we really need to, it's more from our side what we need to do. We need to really, I'm launching like online consultation in order to be able to help patients. So it's not only in Argentina, I can include people that are probably wanting to know how to do it. But I have to work close with a local physician, because if you're taking medications, like you said, you need to know personal history. You need to know. A psychiatric relapse is not a joke, and it's very important to be cautious about this. But like I said before, I mean, a 16-8-hour protocol is a safe intervention. Eating real food is a safe intervention. It's like, that's kind of like weird to say, but improving quality sleep is a safe intervention. So really, these are very, even though it might not sound like it, these are very conservative interventions. I mean, and I start from there. I always talk with my patients. 16-hour fast is like an anti-seismic structure, and I do the same gesture with my patients. It's an anti-seismic structure. This is where we start from. We're going to move from this, but it is a structure that will give you an ability to better manage stress in your life, and it's very flexible. So if you wake up one day and you don't follow it, not a big problem. You get back on track. The moment after you did something that you weren't planning to do, you ate something you weren't planning to eat, or you drank something you weren't planning to drink. So I'm also seeing, really, when you lower your compulsivity, I'm also seeing an easier pathway into reducing addictive behaviors, being whatever, alcohol, tabacism, marijuana, cocaine. I'm seeing, it's if you reduce, a stressed brain will look for a relief. And this is where culture comes in, or your personal history. Some people rely on food, some people rely on other types of substances, or binge watching a TV show or Netflix. So it is a one-on-one work. I'm hoping that more psychiatrists and psychologists jump into this wave, into this movement, because it's really bringing back some of the customs that we had 40 to 50 years ago, really. And it's not intermittent fasting is kind of like a cool name for something we shouldn't have stopped doing ever.
Right. It should just be normal.
Yeah,
and
exactly.
We should have names for not eating that way rather
exactly.
than
Well, Dr. Fung says, 16 and 8 is just like normal eating. It's not like fasting. It's not like a real fasting.
Right.
Actually.
Right. And you brought up a good point about addiction, because it's hard to address all this if you don't also address addiction, which frequently can be carbohydrates. And there's some serious debate about whether it's a true addiction or not. But I mean, there's certainly a subset of people where it seems like it is a clear addiction, and they need to be treated as such. So do you see the same?
I have many patients that have had no problem dropping their smoking addiction, but they're having huge problems dropping sugar addiction and grain addiction.
Yeah.
This has to do with the these substances being so ubiquitous and offered and so socially accepted, and it also has to do with the advance in the development and the design of this food, because we have to remember that most of these foods, when you are carb addicted, it's not really rice, it's not really potatoes that you crave, is that the processing that adds the addictive behavior, and it's also fructose. So I'm a big follower of Dr. Robert Lustig's work, and really has helped me a lot, the approach that he proposes in The Hacking of the American Mind, his latest book. I really love that book, and it really helped me into finding the way between stress, addiction, and the ways you provide relief, and also enhancing, this is very important, enhancing serotonin pathways. There are many natural ways, physiological ways to enhance your feeling of tranquility, and it's not just taking an antidepressant. And this brings me back to a kind of like a joke that I'm gonna tell. Is like, most patients, not most, but I frequently get at the office the consultations, doc, I have low serotonin, I need something to put it up. And this is kind of like the clear example of how this monoaminergic imbalance dogma has penetrated the population. Someone has like, I have low serotonin, I have to put it back and everything will be normal again. Why don't we address what might have happened, why your serotonin is low in the first place?
Right. Everybody wants a pill to fix their problem rather
exactly
than
the quick fix, or
yeah.
or the silver bullet.
Right. Yeah. All right. Well, let's transition for a second. I find it strange that a low-carb movement isn't bigger in Argentina, because Argentinian beef is like the best, right? Tell me about Argentinian beef. Is it really that good?
I have conflict of interest, I have to declare, in relation to meat, because I'm always a very proponent of Argentinian meat. And this is why I tell my patients, we live in the best country, probably the best country in the world, to follow these types of diets. And sometimes the only intervention that we need to do is remove the bread, remove the potato, and just eat the meat. If you wanna eat the meat and then put it some vegetable sides, and have a good olive oil on your salad, and you'll be great. And we have very accessible meat, and especially the meats that I propose my patients to eat, that are not the lean cuts that are probably more expensive, but are the cheaper cuts. That's what I eat personally myself. This is kind of like the diet I follow. I don't only intervene with my patients. I have a lot of friends that I kind of like supervise their diets, and they come to me and say, what can I do? I need to do something about my diet. So there I go, straight to the source, because it's like I said, okay, first of all, cut everything out and focus on meat, kind of like a carnivore transition diet, but not dogmatic. It's not like, I ate lettuce. No, you ruined your diet. No, it's not what I proposed. But it is a great transition, because they get better pretty. They start feeling better. So this, like I said before, they start asking, what else can I do? What else can I add to my life in order to improve it?
When you come to the United States and have the meat here, can you tell a definite difference?
Well, there's definitely a difference in the price, and also the types of cuts that we prefer, and it has to do in the way we handle the how do you call the when you have the
carcass?
The carcass, exactly. It's the way we in the carcass that makes some of the cuts different that we have available.
And what about organ meats? Isn't that much more prevalent?
Much more prevalent, and and this is very sad, because most of it's gratifying for me to tell my patients, eat organ meats because it's like kind of like prohibited by classic nutritionists. They prohibit organ meats, and we have mocheja. Mocheja would be like thyroids, would be like adrenals, and I don't know which other organ mocheja is. That is like gold because it's pure fat. It's very fatty, and it's very tasty to prepare it on butter, garlic, and those are kind of like prohibited in the usual diets. And people, this is the sad part. People remove butter, remove organ meats, remove all the fatty cuts, remove olive oil, remove nuts. It's like they remove everything that is healthy because of this caloric-centric view. It's like the psycho strategy, and it's like, okay, if you want to reduce your calories voluntarily, you will be able to do it maybe for 2 weeks, 3 weeks, but you will relapse. I mean, it's like, because it's not what our bodies and brain expect from your diet. They start sensing that it's a shortcut. So most of the times, most often than not, that elicits stress responses. And this is very important in my practice to address stress levels.
Right.
Because I don't necessarily suggest patients going under severe stress to do long fasts, but I go easier with them, and trying to, of course, reduce stress load, improve sleep patterns. I do a lot of emphasis on sleep, as maybe you've noticed.
Yeah.
And because I think it's like the first step. Like I prioritize sleep and movement. If they are overweight, I don't tell them to run. I don't tell them to do CrossFit or functional training. So like, go for an easy walk, and that's it. But just don't go chasing calories. Just think about trying to relieve stress. Try to connect with the nature. Don't take your phone with you. I use a lot of I talk a lot about technology addiction in my practice, and this is and it's going to be a very big problem for future generations. And if you don't address a technology addiction that is the most prevalent to our cell phones, and nobody forgets their phone when they go out of the house. And it's the first thing in the morning what we do, the last thing we do at night, and this causes most often than not chronic sleep deprivation, and we all know that this increases, insulin resistance and a host of other.
Right. Yeah, great point. We focus a lot on nutrition, and it is so important, prevalent, but there are all these other factors that definitely need to be considered, technology being one of them. And you brought up the calorie restriction part. I mean, the last thing someone who's battling depression and side effects from medication needs is to feel constantly hungry and be counting calories and have the stress from that. I mean, that just seems like a terrible intervention. That why would anybody recommend that? Yeah, but yet people do recommend them. Yeah.
They get better for transiently. They feel better because anyone that start focusing on something, they go to a nutritionist or a medic or a clinical medical professional that prescribes the psycho strategy. They might start feeling better for the first couple of days because they are doing something about them, and right. That makes you feel good. But it's a trap because you eventually fall down of what you're doing, and this will be another frustrating event. So picking up on what I left before, this is a very important message that I like to tell in regards to being a psychiatrist and working with these conditions. It is because many patients come and say, I want to lose weight, and I try to talk them about quality of life and being able to intervene in other aspects of their life. And this is what I call really prevention, and capitalizing on opportunities on the contact of a patient with a health professional.
Right.
Capitalizing each opportunity, because you never know if it's going to be the last opportunity the patients have, or the last time is he or she are going to try to get better. You never know that.
Yeah, very good point.
So capitalization of a contact with the sanitary system.
Right. Make the most of the intervention because you don't know if you get a second chance. Yeah. Well, this has been a wonderful discussion, and I'm so thankful that there are individuals like you taking this message to this whole field of mental conditions and psychiatric conditions, because it's not that different, but yet for some reason it's been portrayed as being so different. So thank you for doing that, for your message, and for taking the time. If our listeners want to learn more about you and hear more about what you have to say, where can you direct them to go?
Well, I'm very active on Twitter. It's Ignacio Cuaranta. I recently launched my webpage in Spanish. I have to do a lot of modifications, but I have a guide for intermittent fasting in Spanish, how to start. I'm gonna put a lot of information up there. This is ignaciocuaranta.com. And also on Facebook, I have a page that is called Flexibilidad Metabólica, where I also upload information or interesting articles, but mostly on those three sites.
Very good. Well, Dr. Ignacio Cuaranta, thank you so much. It's been a pleasure.